Thank you for Dr. Chen for your kind introduction. And dear Chairman, dear audience, it's been my honor being here to give a brief introduction of the robot-assisted transcapital, the TAVR procedure and the TIR procedure. So the first is the robot-assisted TAVR procedure. I think you can say the system is just are composed two parts. The first is the operating system. The second is exclusion system, and you can control the operating system with a remote model, and you can say is a very simple composite of the exclusion system, and you can finish the composite the device in several minutes. Of course, you can get rid of the tower system from the exclusion system in a few minutes. So I think it's safe in some emergency situation. Let me show some case, and I think this is the first case finished in our center, and I think it's the first case in the world with the support of the robot-assisted tower system. I think this is a type 1 bicuspid aortic valve with very severe symptoms, and the CTA you can see severe calcification with left late sinking and the adhesion, and you can see the angle of the ascending arch is sharp. So I think is a challenging case. Even use any tower device with manual operation. And it's Dr. Wang Yan to control the operating system in the control room. You can see after we finish the predilation with 18 balloon, the condition of the patient is stable. So we can composite the robot system in several minutes. Then we can control the tower system to finish the tower procedure. You can see this is the video is show how to control the operating system. I think this this figure your right hands can push the whole system, advanced system, and the left hands can control the stiff wire. And you can see, I think it's the video and the photo is in the same time manner, and you can see this is the Tallness Elite tower system, and that this is a diagnostic device. You can say is easy to cross the arch without any too many resistance. Then during after the device crossed valve, we can also can control the stiff wire to make sure the position of the valve is good. So then we can use this key to deploy the valve. You can say, and you can use this key. This rotate clockwise or counterclockwise to release this valve. You can see the right hand the video, and at the same time we can do the aortic root angle to make sure the position of the valve is good. So after make sure the position is good, we can full deployment the device. And at the same time, you can control the stiff wire push forward or back forward to make sure the operation is safe. Of course, after the post dilation, we can achieve a very good final results, and I think this procedure can be finished in maybe 10 minutes, 20 minutes. I think besides the time issue to complete and get rid of the system, I think the whole procedure time is should be within 30 millions. Okay. So this is a live demo cases. We recorded the whole procedure. This is Dr. Wang control the operating system in the control room, and this is show how the exclusion system work. And this is the flow. Okay, you can say push, 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 push. Then we can, during we cross the arch, we can push this system. Then we can hold the second system to control the step wire to make sure the step wire don't damage the apex. You can see very smooth, and the step wire is very stable. Then we can across the valve. Okay, then we can deploy the valve as a guidance of the ascending angiogram. Then we can wrap the pacing. At the same time, you can control the step wire push or pull. You can control the position of the valve. Okay. Okay, then we stop pacing and the angio. I think the position is a little bit deeper, so we can retrieve the system. You can see. Then we try again, and the first try we a little bit higher. You can see. Okay, much higher than the first try. Okay. After the valve is work, we stop the pacing and to check the position of the valve. I think the position is good. So, of course, we can check the position through the TE guidance. So after make sure the position is good, we can full deployment the valve. Okay. So it's easy to retrieve the whole the system with the operation system. Then we get the angel. Of course, but we need to do post dilate. If we need the post dilate valve, we need to control manually. So I think it's the final result. I think that we can achieve a very good the hemodynamic results with mild to trace PVL, and I think it's very good results. Okay. So I have also finished the FAME procedure, and totally 5 cases are included in the FAME study. This is the results of the FAME study. I think you can say the duration of the procedure is for 3 cases is less than 20 millions. The one case is 24, and the last one is 34 millions. I think the reason of the long duration is due to something wrong with the system. We recheck the system and we include all the over time into this procedure. I think the dose of the radiation explosion is extremely lower for the operator, and you can see we achieved a very good hemodynamic result of the procedure with the mean gradient maybe 2 or 3 millimeter accuracy with multiple choice PVL. I think it's very good results. I think the second part of this lecture will introduce the robot-assisted tier. And the robot-assisted tier procedure has been established in the alternatives to surgery for the patients with high risk mitral regurgitation patients. I think the feature of the robot-assisted TIA procedure can finish the procedure with remote and stable controlled clip device. The first robot-assisted mitral TIA was performed in Xiamen Cardiovascular Hospital in almost 2 years ago. I think this is the third plus robot system, and I think including the three part of the component of this system. The first is instrument platform, and second the hostel journey, and the third is the doctor's console is same to the operating system of the TAVR procedure. And I think this is how to control the operating system, and this is the instrument platform work. And I think we can control the host system as the guidance of the TEE. So I think this some the components of the list system, and is including some elements to control the steering guiding catheter, to control the clip delivery catheter, and the clip control sheath. So all the procedure can be finished by this robot-assisted system. And I think this is the control system. We can control with dividing the three parts of the control system. The first is control the guiding catheter, steering sheath, and the deliver catheter. We can advance or backward the deliver catheter. It can grip down, grip up, use this knob, and it's easy to control and easy to learn. I think this is the video to show how to use the robot-assisted system to finish the TAVR procedure. And this is the knowledge of this operating system. And you can see, and this is M to control M knowledge. And you can say open the clip. You can advance the clip, the deliver system. You can grip down independently, grip down, grip up. Then we can close the grip, and we can test we can learn how to control the G4 system out of the body on the table, and it is very easy to learn with a very short learning curve. Okay, you can see. I think this is some data about the early feasibility trial. This is a 5-tier procedure is finished in our hospital. I think the FAME trial are finished in Xiamen Cardiovascular Hospital and the Fuwai Cardiovascular Hospital. And in our center, we finished 5 cases, and another 4 cases was finished in the Fuwai Hospital. I think it is the data of the FAME from our hospital, and including the DMR and FMR with 4+ mitral regurgitation, and with the proper length of the anterior and posterior left leads. And this is the data operation. This is the mitral regurgitation, the severity of the MR after the procedure. And this is the 30 days clip follow-up. And for 3 cases, we use 1 clip. 1 case is use 2 clip, and 1 case is use 3 clip device. And this is the characteristic, imagine characteristics, and you can see that the mean area is 5.5. All the patients are in GA, and the procedure time is more than 20 minutes. And this is the outcome: no deaths, and all patients with the significant mitral regurgitation reduction, and the success rate is 100%. Device rate, and the procedure rate is also 100%. This is the 30 days outcome. You can say this is the function. The heart function are improved significantly, and this is the severity of the mitral regurgitation is good after the 30 days follow up. And this is this figure shows the improvement of the heart function. And this is show the persistent reduction of the mitral regurgitation after 30 days follow-up. Actually, next we'll show some cases, and I think this is a 85 years old lady. And I think this is a DMR with posterior prolapse. You can see a very severe mitral regurgitation with a significant PSAR. And this my PR view the mechanism of the mitral regurgitation, and and you can see the severe. This is the evaluation before the TEER procedure, and this 3D showed very severe regurgitation. And this is the puncture, ASD puncture, the transeptal puncture, and you can see a very large left atrial, and this height is okay. And this is we can control the clip to the left atrial and add some M, and you can see the orientation, the trajectory of the clip is good. So we can try a little bit aorta hug, so we can make some modification to release the aorta hug. You can see it's much better after some adjustments. And this is the first try to grip down and grasp in the close. You can see the regurg are reduced significantly. So some radial regurg at the lateral side, and we tried the second clip. You can see this is the final result. You can see maybe trace mitral regurg after the procedure with a very good hemodynamic improvement after the procedure. I think the third case is DMR cases with the ischemia, cardiomyopathy, severe MR, severe TR, and severe pulmonary hypertension, and with extremely large LV dimension cavity, and with severe impaired LV function with the EF 26% with the PSP 68 millimeter accuracy. I think this is a challenging case because of the mechanism of this MR, and the area is 4.7 centimeters square. The gradient is 2.7 millimeter accuracy. So I think we use the G4 system. They use the XTRW device, and our target is the A2P2. And I think we just use the one XW to finish the procedure. You can see we achieve a very good result with the radial MR 1+ and the gradient 1 millimeter accuracy. I think the X-ray time just 21 millions, and very good final results. Okay, so I think we are on the way to very familiar with the robot-assisted TAVR procedure and the TEER procedure, and the Dr. Wang has introduction our early experience to use the robot-assisted TEER procedure in the FAME trial in the TCT conference, and we have finished the TAVR, the robot-assisted TAVR FAME trial, and both the robot-assisted TIR trial compare with the robot-assisted and the manual control for the TIR procedure and the TAVR procedure. We have finished the RCT trial design, and the TIR is on the way to of the RCT trial, and has recruited more than maybe 40 cases in the robot-assisted TIR RCT trial, and I think for the TAVR, the TIR report, TIR assisted, the robot-assisted TAVR procedure RCT trial is on the way. Okay. So this is my brief introduction to robot-assisted the interventional valve interventional study. Thank you very much.